To do too much about like I was saying, this is about you guys. This is not about us and who we are and all that. But I will before each speaker comes, I will just give you a brief introduction about them. First thing, I'm Shishir. I'm a pediatric anesthetist and also head the department of anesthesia at a place called Sakra World Hospital in Bangalore. I trained here in MMC, Mysore Medical College, both my MBBS and MD, and then I spent about 12 years in the UK, where I trained and was a consultant at Great Ormond Street Children's Hospital before coming back to India. My areas of interest, of course, are pediatric anesthesia, TCI. I've been using TCI for the better part of 20 years now. 2004, I learned TCI from my teachers in the UK. So it's a technique that is, like I say, quite old and mature. So we will first look at why using TCI is a good idea. Is it even a good idea in the first place? Why should you change your practice, or should you consider adding this to your armamentarium? I think it's more that than changing your practice. Your practice is probably pretty good as it is. So this will be a quick 10-minute talk where we will discuss about why I should use TIVA, why it's a reasonable option, how it is different to the anesthesia that you're currently using, what are the real world advantages. Does TIVA really offer any advantages for the practicing anesthesiologist, or is it just one of those nice things that you read in the books and answer for 10 marks and you forget about it? Can we use it in the Indian context? Like I said, it's largely a European concept, and everything that happens in the West may not necessarily be translatable to our population, and our mindsets are different, our physiologies are different, our resource constraints may be different. So, but we are talking about using TCI TIVA here in Mysore, in Bangalore, and wherever else it is that you guys are coming from. So whether we can use it. And overriding principle, is it safe? Is it something Wild West that we are trying to do? And that is something that we will also look at. And this is not just my talk, this will be the combination of themes that all of us will explore through the course of the day. So first of all, how much of TIVA is actually being used currently? Short answer is we don't know, because there are no real surveys in India, but it's reasonable to assume that it's going to be very low, because most places you work in probably will not be using TCI TIVA, and maybe less than, if I had to hazard a guess, it will be less than 5% of anesthetists who would have had any exposure to TCI TIVA at all. But in the UK, in Europe, it's an extensively used technique for the last 20 to 25 years. In fact, there is a Society of Intravenous Anesthesia of the UK which has been in existence from the 90s, and they conduct courses regularly, they conduct annual conferences, workshops, and the Royal College of Anesthetists now stipulates that every anesthetist and every qualified anesthetist should be able to deliver TIVA by TCI. So this is no longer a nice thing to do, this is now regarded as a core competency of every anesthetist in the West. Hello, welcome. Hi, please. So we just got started. I'm Dr. Shishir. I'm the pediatric anesthetist and head of anesthesia at Sakra Hospital in Bangalore. So we were just exploring why, first of all, is TIVA a decent option to use, and if yes, why we should be learning. So we were just going through. This is literally the first slide. Like I say, now it's no longer a nice thing to have. So I expect all of you, in a few years' time, even in our context, it will be an absolute core competence that will be demanded of every anesthetist. So please think of it like that, and a technique to use. And many anesthetists, I would say up to 20 to 25% of UK anesthetists use TIVA as their default technique, and they do not use vapor at all. In fact, there are many OTs, complexes in the UK where the back bar of the anesthetic machine is bare because nobody uses any vapor at all. So it is definitely a time-tested, proven technique. So my own practice of TIVA is quite wide and varied. I use TCI, again, TCI is target controlled infusion, and Dr. Arun will next talk to you about the pharmacokinetics, about it, trying to not keep it dry, we'll try and make it as interesting as possible through the course of the day. It's about 30 to 40% of my practice is TIVA, both adults and peds. In adults, my default model is Schneider regimen, which we will come to during the course of this day. When I do pediatrics, I've used Pedfuser and Kataria, both are long-standing models which are proven. And when we have not had access to a TCI pump, we have used something called the manual Stewart regimen for a small baby. I think Dheeraj and I were there for that case. It's a 6-month-old baby. We were trying to preserve the bulbocavernosus reflex because they were doing intraoperative nerve monitoring, and when any even 0.5% of SIBO was enough to obturn those signals. So in that kind of situation, we have used even in small babies. So it's quite wide and varied is what I would say. So I hope for a day when we don't have to justify indications for TCI TIVA, because TCI TIVA is essentially an alternate philosophy of anesthesia. It is not that you have to find a reason to use TIVA. Anywhere where an anesthetic can be given, TCI TIVA can be used. But for the purposes, how many are postgraduates here? Especially for the purposes of the postgraduates, this is the question that will get asked as an exam question also. You could conveniently group it into three things: patient factors, surgical factors, and procedural factors when we want to be using TCI TIVA. Where there is a proven history or a suspicion of malignant hyperthermia, it's a no-brainer. You cannot use volatile anesthetics in that situation. So TCI TIVA comes to the rescue in that situation. Where there is a history of muscular dystrophy, again a predisposition to MH, predisposition to what is also called AIR, I don't know if you've heard the term, anesthesia-induced rhabdomyolysis. So it's distinct to malignant hyperthermia but presents in a similar way. So in those kind of high-risk cases, you would definitely need to use TIVA, okay? Where there is central core disease in kids, increasingly, so these are that's why I put it in red, they are like no-brainers you have to use. But they're getting more and more softer indications coming along now. Those with a known history of severe postoperative nausea vomiting, TIVA is an excellent technique to use because you will greatly reduce the risk of PONV with this. Kids especially, and even adults who were exposed to sevoflurane, for example, many senior anesthetists among us see they really wake up agitated. Emergence delirium is a real problem, especially in pediatrics. And there again, TIVA with calm recovery and a good recovery profile, very alert recovery profile, comes into its own there. Where there is, and again, next is surgical factors, where there is shared airway work going on, because you are sharing the airway with the surgeon, again, TIVA comes into its own because you essentially decouple the airway from anesthesia delivery. Because often what happens is because you're sharing the airway, you also have to give the anesthetic through that, and they have to do their thing through that as well, isn't it? But the moment your anesthesia is given through another room, all you're thinking about the airway is for oxygenation and CO2 elimination. And consequently, you are able to do more complex, intricate procedures on the airway if you become well versed in TCI TIVA. Where there is need for intraoperative neuro monitoring, any of you here working in neuro centers where they use nerve monitoring? Yeah, you do. Which hospital? Shankara, Bangalore. Yeah. So they would be using, and in our hospital, for example, Sakra, Dheeraj will talk nicely about it at a later point. We use a lot of intraoperative neuro monitoring. There, even 0.6, 0.7 Mac of sevoflurane is enough to obtain the signals. You don't get good MEPs, you don't get good SCCPs. So for that, to preserve that, propofol and TCI propofol is an excellent way of doing TIVA. And again, for the purposes of our discussions today, we will think of this as classical TIVA. Okay, classical TIVA is propofol and remifentanil. There are multiple various other combinations. You can add dexpran, you can add ketamine, you can add a whole host of other drugs. But for the sake of people who are initially getting exposed, my advice is please stay classical at the beginning, then think about adding drugs, and even then do not ever add them into the same syringe. That will come to at a later point. Okay. So neurosurgical procedures, again, TIVA comes into its own. We are lucky to work in a hospital which has an MRI compatible anesthesia machine, but if you are working somewhere where you do not have an MRI compatible anesthetic machine, TIVA can still be used. Of course, you have to stay outside the immediate zone. You could keep it out the door and essentially run a long infusion and keep your patient sedated, because they don't really need anything more than sedation so that they can lie still for the scan. So that is another area where you'll end up using. And where there is muscle biopsy being taken with a query neuromuscular problem which we don't yet know about, again, it will be useful. So 3 or 4 benefits, we'll just focus on. The rest other speakers will talk during the course of the day. Main benefits, if I had to put down in my practice from having used TIVA, they are these: decreased postoperative nausea vomiting, decreased emergence delirium, decreased risk of laryngospasm. In fact, laryngospasm is one thing that we are mortally scared of, and rightly so as anesthetists. Whether it's adult or pediatric practice, the risk of laryngospasm greatly comes down, especially when you consider propofol and remifentanil. Remifentanil is an excellent cough suppressant. And again, Remi is almost here. I think she assures me it's going to be in the next month or so. It will be licenses are being taken all over. So when that comes, that will change your practice. propofol and remifentanil anesthesia will change your practice, and then it will start getting more and more. So you're kind of ahead of the curve, which is a good place to be to learn this thing. Yeah. And of course, increasingly theatre pollution is becoming more and more recognized. Scotland, you may have read, has already banned desflurane. NHS England is going to ban desflurane from next year. And there is, and at some point I will talk a bit about the carbon footprint of the anesthetics that we typically give also. So, this is, and theatre pollution. So often our patients have about 1 Mac, especially if you're doing kids. You have about 0.3 Mac yourself because you're right there. And it's just that you're not measuring, so you don't know. So you can actually do with 0 theatre pollution if you use TIVA. So now each of this in its own. Nausea, vomiting, anywhere between 10 and 20% incidence. It's higher in kids, in fact, over the age of 3. They are twice as likely to throw up as an adult is. There's a strong association with volatile anesthetics, as we all know, especially nitrous. If you're using nitrous, please stop. So is the short thing I would say, except for induction. I still use it for the second gas effect for induction, but beyond that, there's no real role for nitrous oxide, but that's a separate discussion. And TIVA, actually, you'll be surprised to know, it's as good as giving a single agent. It's as good as giving dexamethasone. So TIVA as a technique itself is an antiemetic. Okay? And the number needed to treat, so this, for especially PGs may not be aware of this one. So every 5 kids, every 5 adults you give TIVA for, 1 of them will not throw up as a result of that. So it's a very strong. So the lower the NNT, the more compelling the case for that particular technique. So an NNT of 5 is actually very, very small. It's a very good indicator to do TIVA. Again, kids, between 1 in 2 and 1 in 10 kids becomes really irritable in recovery. I'm sure all of us have seen this and encountered this, and you've become nobody's friend, not the friend of the kid, not the friend of the parents, not the friend of the recovery nurses. Okay, and there it's particularly common with sevoflurane. But TIVA has been known to, so significant difference. So this was a study from a few years ago now, from about 2013 actually, by Answerin et al. And they showed that in squint surgery, the emergence delirium was as high as about more than 1 in 3, was reduced to about 1 in 6. So pretty compelling evidence. And again, the number needed to increase, NNT is only 4. So every 4 kids you give TIVA for, 1 of them will not scream their heads off in recovery. This is a pretty compelling case. Finally, airway reactivity, and this is usually the commonest reason people end up using TCI TIVA. Okay, it greatly reduces your chances of getting coughing, bronchospasm, laryngospasm, and during the cases today, we hopefully will be able to demonstrate the quality of wake-up will be good. Again, this is not our home turf, this is not the place where we normally work, so there may be slight hitches, so please forgive us if that happens, but we've all come yesterday, familiarized ourselves with the place, and the excellent support of Madhav and Balu, we should be able to prove it to you. But you have to take my word for it that because you're using it every day, there is a definite difference. Like I say, no risk of ambient pollution. It is probably better for those with a recent URTI, whether kids or adults, because of obviously increased airway reactivity, which persists for as long as 6 weeks. So when you're using good, bronchodilating properties of propofol, plus the cough suppressant properties of both propofol and remifentanil, it comes into its own. Okay? And also, hopefully today we'll be able to show you with that ERCP case that it's possible to titrate it nicely up and down, preserve spontaneous ventilation also, so you don't have to always intervene from an airway point of view. And we will put Thrive, so to make sure that oxygenation is safe and effective. Okay? And we'll be able to do, TIVA is a good study for kids and adults who come for repeated scopies, for microlaryngobronchoscopies and bronchoscopic ultrasounds. In that situation, they want the dynamics of the airway to be kept open. You don't want a flat patient who's muscle relaxed, because that's not how they are in real life. So in that situation also, it will come good. So if it was that good, why is it not being used? It's mainly because remifentanil is not yet available, and when it comes, it's likely to be expensive is a fear. We don't yet know the cost, so we can't really talk about it. And that's why I didn't use after coming back to our system for a few years. But then I realized analgesic arm can still be managed just fine with fentanyl and morphine boluses, which we use regularly in our hospital. And the amnesic component with propofol, it works just fine. We've not had PCI pumps till lately, but now we have, I think, 4 or 5 different ones to choose from. It's not expensive, and I'll come to the economics of that at some point in the afternoon. It is at least cost neutral compared to the anesthesia that you and I are giving today. Pain on injection was an issue, but that can be surmounted. Propofol infusion syndrome and risk of awareness. Just come to, I've got 2 more minutes. I can talk. Pain on injection, the way to reduce that is to use as big a vein as possible, giving some lignocard, so preservative-free lignocaine, and what we do, and today also I think our guys will show you, is just put a bit of a venous tourniquet, you're giving it for the local anesthetic effect, not for systemic effect, okay? And once you make that, I think many of you here are using it, they're nodding in agreement, so I think especially I'm aware that we have people of different seniority, so I'm pitching it for the postgraduate so that they understand what we can do, okay? And lignocaine you could use, and pre-treating with fentanyl or opioid also works very well. What about propofol infusions? So this is one question, again can come up as a question for the PGs. It is one of the big fears in TIVA. Okay, this is something we need to address. So that's why I'm just put it. First thing to say, it's never been reported in an operating room environment. Okay, it's only ever been described in a PICU. Again, not an adult ICU, but a PICU in kids who had more than 2 days worth of sedation at greater than 6 mg per kg per hour. So this is nothing like what you will encounter in OT. Okay, however slow your surgeon, they're not likely to take 2 days for an operation. They're not likely to give more than 6 mg per kg of propofol either per hour. Okay, so that's very important. But when it happens, it's potentially catastrophic. It results in rhabdomyolysis. It results in quick, rapid acidemia and progressing on to liver failure and multi-organ failure. So the ways to counteract that is, the common thing to do is we use 2% propofol. Okay, that's what we use in our hospital, and we've actually got a few samples also we brought along so that you can. So the problem is not from the propofol; it's from the lipid component of it. So the moment you, instead of using 1%, you use 2%, then automatically you're halving the lipid load. So you have, each ml has twice as much, 20 mg per ml of propofol as opposed to 10. So halving the lipid load has helped a lot. But still, you have to be careful. Very rare that you are going to encounter somebody with lipid metabolism, but if they have that, definitely don't use TIVA. And in those kids with MRFs and MELA, so mitochondrial enteropathies and tag and thread fibers, and also where they have known history of mitochondrial, so this is maternally inherited problem. Unlikely that you'll encounter this unless you're working in a specialist pediatric center. There you wouldn't use TIVA. Awareness is a big risk, and that's why we have kept on specific topic. Dr. Dheeraj will talk to you about depth of anesthesia monitoring during TIVA. Because one of the fears we have is for volatiles, we have MAP. What do we have for TIVA? We have nothing, is what you would think. Okay? But of course, we have more processed EEG, and he's going to talk a bit more about it. Again, it's important. NAP5, every year the Royal College of Anesthetists do a huge, what's called a national audit project. This was about 10 years ago, where they looked at a 2-week period of all anesthetics given across whole of UK. I'm not using UK because I trained there. I'm using it because they are the ones who have the best data. Similar things will be happening even here. So, but this is data we have, so that's why I'm using these numbers. So, 2.8 million GAs were given at that time, and there were 141 cases of reported of awareness. So, they were looking specifically at intraoperative awareness. In these 141, 18% of them involved TIVA, which would seem like quite a high number. Okay, so that all kind of started making people wonder: are we using the right technique? Are we sure our patient is asleep? But the important thing to understand is TCI TIVA, as Dr. Arun will next speak to you, is something called the BET principle: bolus, elimination, transfer. But when they dug deeper and looked at what the causes of the awareness was, it was because they were running fixed rate infusions. You were just running, say, 10 ml of propofol an hour and sending the patient either from OT to a scan and back, or from OT to ICU, or bringing from ICU to OT. So that is the point they were having awareness. So it was not the technique to be blamed, but the fact that we were using a fixed rate infusion as opposed to a bolus elimination transfer, which is what TCI is. And again, I always tell my team that I've cried myself hoarse saying this again and again: don't use relaxants unless it's necessary. Don't use relaxants by the clock. Okay. Only if the surgery mandates the need for relaxation, you can use. After the intubating dose, many times 3-4 hour cases, we don't even repeat a relaxant. Because the big fear is not just of awareness, but of awareness and an inability to communicate that to us. And that only happens when they are paralyzed. Otherwise, you will pick up if someone is light, isn't it? So if, this is pediatric related. If you don't have a TCI pump, some of you here may have to. I hope you're able to go and get a pump because it's not that expensive. But if you can't, also you have manual regimens which you can use. Something called the Bristol regimen, which Arun again will talk about. In kids, something called the Metformin. Let's not go into too much detail. And for very small kids, we have something called the Stewart regimen, which we have also used. But the bottom line is, this is Gillian Lauder, one of the thought leaders in anesthesia, saying even in pediatric anesthesia, she expects that TIVA will eventually supersede inhalational anesthesia. So this is the, I think Dr. Shiv also said earlier, this is the future of anesthesia, and I think you guys have to learn it. You have to, and once you start learning it and start using it, you will fall in love with the technique. I can guarantee you that. So I'll stop at this point, and then what I think we'll do is we'll request Arun to come and talk.